What if I was to tell you that therapy does not work? Well, I would be lying. But for those of you who have tried it and it hasn't worked out for you, and those of you who are worried about getting started with it, that does nothing for you necessarily. So let's reframe it. Therapy isn't what you think it is. So, what is it? Well, you could say it's one of those questions that's easy to answer, but hard to explain. It's kind of like pi. I can give you 3.14, and that's useful, but it's also not pi, and it never will be. And, similarly to pi, the more that you try to list that sequence of numbers, the more you realize that you'll never reach it, because there's so much more than you could ever describe. Now, similarly, the basis of therapy is rooted in psychological theories concerning intrapsychic functions of the mind, which then branched out and spawned subsequent theories about social interactions and how these reflect in our psyche. Now, this is something objectively positive for the field, because the research that's been done into these theories have spawned all kinds of empirical works that help us delineate what are the best treatment modalities for certain conditions, and then categorizing those conditions themselves. And it's particularly useful for therapy because we can operationalize all that data we have to really build up an evidence-based practice and make better treatment modalities. In other words, therapy is a process that helps you try to become the best version of yourself through the lens of psychological intervention. It involves identifying problems that are currently stopping you from being able to do the best that you can in one of many given domains. And it's also there to help you to realize things about yourself which may be preventing you from reaching the milestones that you want, or maybe to uncover that the milestones themselves are the product of some misinterpretation of yourself. This does, however, create a double-edged sword, because on the one hand, it's great that so many empirical studies exist, and we have so much data that has helped us categorize and understand mental health conditions, but it also creates a lot of opportunities to do the wrong thing. Assuming that your therapist is educated, well-studied, and intelligent, then it still leaves the opportunity for them to use the incorrect treatment modalities to suit your individual needs. And that's not just because of the fact that they might misunderstand what modality works best for a specific condition. The real problem is that everybody has their own idiosyncrasies, and that creates a dynamic where you have to intuitively understand what that person is experiencing and then apply your knowledge to said person. In the words of Robert Johnson, every person must live the inner life in one form or another. And that creates the first real problem here, which is that the outcomes of therapy can be hard to predict and fluctuate wildly. For instance, what if I was to tell you that there's a treatment out there, let's say TMS, that's 90% effective at managing symptoms of depression? Well, it would be an exaggeration, as TMS tends to only show 50 to 60% effectiveness in research trials, but for the sake of argument, let's bump this up to 90%. What does that actually mean? If you're unfamiliar with statistics or you haven't read the study itself that's producing that number, then it might come across like 90% of people are benefiting from TMS treatment, or you might understand it as 90% of the depression an individual has is being cured or managed or mediated somehow. But in reality, effectiveness usually doesn't refer to either of those things in research trials. Effectiveness is defined as the proportion of the people in the study whose symptoms drop by some percentage, usually around 50% in the social sciences, as a result of an intervention. Now, this is exactly where the problems start to arise for individual practice, because you take a treatment modality, let's say that's super effective, like 90% of people are having a 50% response. That doesn't actually speak to the nature of the individual case, because if you are getting a client with somebody like, let's say like they're scoring a 26 on like a PHQ-9, for instance, which is like significant depression. You can say that they have a 50% response to that, and that's being reduced to a 13. But clinically speaking, that would still suggest that you're dealing with moderate symptoms of depression, which may still require some professional intervention, especially if you have low distress tolerance. Now add to all of this that assessments like the PHQ-9 and the HAM-D measure subjective self-reports. And really think about that for a second and what that means. It means that what you're measuring is the subjective symptoms that people are going through based on the questions that you're asking them and their response to it, which can change pretty frequently, and it can change on a day-to-day basis just because of the fact that you are more likely to choose something that is more extreme or less extreme depending on the day that you're already having. Now, obviously, people go to therapy for specific reasons, generally to work on topics which are psychologically distressing, such as trauma, problematic behaviors, or maladaptive personal schemas. But as I said before, therapy's core essence is to make you the best version of yourself possible through the psychological lens and using empirical data that we have to help support that. But fundamentally, that's abstract, so a lot of the therapy that you're going to be involved with generally tends to be around designing what that's actually going to look like through collaboration, which is a very important part of therapy because you need collaboration to build on your prior understandings of yourself and where you want to end up. Now, again, if we assume that your therapist is doing their job well, then that means that you'll need to collaboratively concretize these abstract ideas that we've been talking about and turn them into workable goals and then actually work on these goals. This is the point in therapy where I think a lot of people fall out of favor with the practice, or they end up quitting, or they can't get past a certain point. Because at a certain point in therapy, if you're working with a therapist on a long enough time scale, you'll eventually have to encounter your own resistances. And trying to get through that is very difficult because being told you're wrong doing something, it activates exactly those resistances that have kept you doing the thing that you've been doing. And so this is sort of the part that people don't really mention for prospective clients or patients, which is that therapy is work. Hard work. And the reason is because the path towards insight and self-improvement is almost never clear initially. What percentage of people do you think leave therapy within the first 3 sessions? I imagine the answer will vary pretty widely, but the true answer is somewhere between 25 and 40% of people will not return after 3 sessions. And this represents one of the initial obstacles of therapy, which is the dedication that you make to try and change yourself, as well as the need for consistency inside and outside of sessions. Now, this represents one of the first barriers to therapy because it's difficult to maintain consistent discipline and commitment to making these changes, especially when you're outside of the therapy room. It's less costly to play with ideas and theories about why things are the way they are and how they could change than it is to believe in them so deeply that you're compelled to action. As a therapist, you're most likely to see this dynamic play out in cases where people are dealing with an eating disorder or when they're dealing with a substance use disorder, particularly when they're dealing with alcoholism or opioid addiction. And now the reason for that is clear, right? Because those two cases have to deal in large part with differing understandings of what is the most important thing and the most practical thing to be concerned with at the present moment. If you have addictions, then it can feel impossible to cease use over a long enough period of time because of repeated experiences and increased dependence. Likewise, if you have a warped body image but genuinely believe in the accuracy of your opinion, it can be hard to consistently hold a stable point of view from which long-term change can be made. Conversely, this is why you see people with anxiety disorders and mood disorders leave at fewer rates prematurely. It's because that subjectively, this is generally an unpleasant thing to be dealing with, and there's no real room to be like, oh, well, you know what, this is actually warranted, or this is good for me in some capacity. Because again, it's generally unpleasant. So one way to overcome this barrier, if you're a prospective patient or client, is to work on your insight. Now, this is another one of those things that a lot of people won't tell you, but insight is really like building a skill. And one of the best ways of doing that is through Socratic questioning. And you can use this technique even outside of therapy, right? I mean, what it is essentially is just asking yourself question after question regarding one or more problems that you otherwise may be suffering from. Let's say you've been given a diagnosis of major depressive disorder. You can use Socratic questioning to reach deeper levels of insight based on the most problematic elements of your life. For instance, if you want to ask, what makes me so depressed, then this can be the first step in a series of questions which can lead to new understandings of yourself, which you may have never realized. Now, I'd be remiss not to warn you that this is one of the more difficult parts of therapy to get through, because it's really easy to concretize your resistances. For example, if you have a mother or father who's in the hospital and that's making you feel depressed, then that's a really good rationalization to feel depressed. Likewise, if you go off to work and you hate your job, it makes sense that you would come home and crash rather than crashing at your job because you need to be able to make money. And this is the thing about therapy, right? It's like none of those things don't make sense. You know, all of those things are rational. They make logical sense that you would act in those ways based on those events happening. And a good therapist will be able to collaborate with you and be receptive towards the needs that you have in the moment. But if you fail to confront these rationalizations or displacement, it likely means that this way of thinking and behaving will turn maladaptive on a long enough timescale, which can lead to negative thought loops or problematic behaviors that damage emotional well-being or success. Oftentimes, therapy also is not a linear process, meaning that there are different highs and lows throughout the sessions. And for a lot of people, that can become frustrating, or they can maybe leave too early if they reach a high and they think that they're all good for the problem that they came initially for. So, working on your distress tolerance and having an encouraging therapist are some ways to buffer that out, right? But this is why it's so important to stay committed to making the changes that you'll identify as conducive to a long term positive outcome. If you can get past all of these initial barriers that we talked about in the beginning of this section, and you get to the point where you begin to learn tools and gain new insights onto the problem at hand, then it really helps to be able to stay committed to making those changes through maybe altering your lifestyle. Maybe it will require switching jobs, reducing media consumption, increasing exercise, or something more unique to your situation. If you can stay committed to yourself, increase your insight, and throughout this whole process, you can manage to stay open and vulnerable with your therapist and be open to the idea of potentially being wrong and mediating some behavior, then you're really setting yourself up for the best possible outcome. Okay, so up until this point, this video has mostly been pointed toward people who are either thinking about going back to therapy or trying it for the first time. But there's another very important dynamic to consider in why therapy doesn't work. So, as a foreword, I did want to mention what I've noticed in contemporary history as what you could call an advertisement for getting therapy. And the problem with it is that it doesn't come off as being attractive as a practice. What I mean by this is that the scientific nature of psychology and the public perception of therapy both sit with untapped potential due to the mishandling of practitioners. People like Aaron Beck and Irving Yalom, who had once held near celebrity status in psychological spaces, never exploded into the public scene in the ways that Dr. Phil or Jordan Peterson had, and the effects of this have considerably damaged the reputation of psychology as a practice. It's really difficult to mimic the importance of something like a default mode network, or generate the interest of something like watching therapy get conducted on TV. And to hold both of those things while still being in the guidelines of ethical principles is even more difficult. Conversely, what we get in its place in the public space is oftentimes less professional and more pretentious or ostentatious. You go to something like therapy, TikTok, or Instagram, and you'll find that this is the only type of content available. The academic space also has some problems, albeit a little bit smaller than what we've just discussed, because of the cardinal role ideology has taken in forming the basis for different studies to be created and also informing the insights on New Age therapy. There have been many great advancements in psychology as a result of both behavioral and cognitive sciences, and that even overlaps sometimes with the branch of natural science. But therapy, in reference to mental health, almost always draws its insights from social science, specifically sociology. The problem with this is that many of these predominant sociologists come off as ideologues, so the therapist or the therapist-to-be will read their work in like an academic text, and then what will happen is they are in charge of operationalizing those insights and bringing that into the therapeutic space, where they can use that for the betterment of the client. Now, fundamentally, this is an incomplete way to train new therapists, and most schools will not assign only seminal texts or ideologically driven academic papers. Any real program a therapist goes to also includes a plethora of information on evidence-based practices found to be useful in empirical studies. The real problem is that these empirical studies are rooted in insights based on these ideological sociologists. A significant portion of contemporary academic literature you read will be molded by some variation or offshoot of critical theory, which is a concept originated by a century-old institution known as the Frankfurt School. Critical theory espouses that people and their environments are inextricable from one another. They cannot be separated and identified individually. They develop each other. The individual has an effect on their environment, and the environment subsequently has an effect on the individual. Now, that's not a new idea. That's something that's been proposed long before the Frankfurt School. But the thing that makes this unique is the insistence on the nature between power dynamics, specifically between the oppressor and the oppressed. It's often said in a variety of ways, but the message is consistent and clear. People exist within hierarchies. These hierarchies dictate the environment, and when they're oppressive, which many sociologists in the psychological space would agree they fundamentally must be, they become antithetical to positive mental health. Now, this position can produce some valuable insights, like if you're working with a veteran who has PTSD from war, or if you're working with an individual who's living in a really dangerous part of the country, then that really is inexorable, their individual psychology, from the environment around them, and it fundamentally has to do with seeing oppressive dynamics in action. But the problem is with empirical research is that a lot of it, again, is crafted by this understanding. So when we're trying to think about ways of approaching studies or scientific topics, it's hard to do that outside of this lens in the modern day psychological space. Now, obviously, there's other works available outside of this scope that are also rooted in sociology, but what is most present on the mind of many active therapists are ideas that are downstream from this train of thought, such as feminist principles and social justice advocacy. And while I could make an entire video on that, this is the perfect time to transition to the final part of this section, which is the professional problem. Now, as I explained before, the title is sort of a misnomer because therapy actually does work, right? I mean, given a good practitioner and given their specialty in a given area to meet the client's needs, it is shown to be effective. But it could be more effective, and broadly, I see two reasons as to what stops this from happening. The first, as I just discussed, has to do with the sociological emphasis that takes place during college and graduate school, and how this primes new therapists to conceptualize cases. Probably one of the best examples of this that leaves clinicians handicapped is the insistence that they look into their own biases so that they come to the therapy sessions prepared to deal with differences that arise from different characteristics between yourself and your therapist. The literature often refers to this as some deviation of bias, whereby the therapist, if they're not careful, may exude some racist tendencies, some sexist tendencies, some homophobic tendencies, misogynistic tendencies, and the like, which can leave patients feel misunderstood and actually have a worse mental health outcome. I'll read you a quote by Daryl Wing Su, who's currently a professor of counseling psychology at Columbia University, and you can tell me what you think, because this perfectly encapsulates the overall point. Individuals who have come to recognize and own their biased beliefs and prejudices, their roles in perpetuating racism, the pain their obliviousness has inflicted on people of color, and their privileged and advantaged position in society may feel overwhelmed by the magnitude of the problem. When educators lack critical consciousness about race/racism, have not adequately dealt with their own racial hangups, and are uncomfortable and unprepared to deal with difficult dialogues on race, they become part of the race talk problem. Now, without getting too deep into the nature of bias, because that can run down its own rabbit hole, this statement really captures what is taught to new therapists when they're going through the educational process. And insofar as they do that, what they tend to find is that there are a lot of statements that come from sociological lenses like this one, where it alludes to the need to confront your own biases. Now, that doesn't have to be a problem in and of itself, but the thing is, again, the nature of bias is amorphous, it takes on these different forms. And so when you talk about confronting your own bias, what you really talk about is the things that are making you feel guilty about the presumed privilege that you have in society, and the fact that you may be ignorant and unaware, and likely are ignorant and unaware, of the way that other people suffer due to their characteristics. There's a real opportunity within this dynamic to explore these so-called biases, but it's often guided by guilt or shame, and this can leave clinicians feeling tepid or unprepared to broach controversial issues or potentially offensive dialogue. I remember having a conversation once with one of my professors while in graduate school, and it was about this exact topic. And as we were talking about it, it was very interesting because I started to bring up these things that I thought maybe counted as biases according to everything that we were reading and everything that they were saying. And what they had noted was that that it was, in fact, all of these things were biases. And the most memorable one of these things, and I'll never forget this, I asked if English fundamentally then is a bias, because if you speak English, then that means you're filtered from understanding the ways that people who speak any other languages, like Mandarin or Spanish, because they have their own ways of conceptualizing things based on their language. And gleefully, she agreed that it was in fact a bias and that she thought that I understood exactly what they were talking about. So, you have an entire field of clinicians now who've been given the prerogative of examining these types of biases. But again, since this is often guided by guilt and shame, there's a real risk of your ability to generate intuitive insights on patients you meet being handicapped. If the outcome of this process results in you feeling as though you are a biased person and that you think that all of your beliefs are subjective or that they're principally based on things that you otherwise don't want to be associated with, then it leaves you in a position now where you understand the subjectivity of your own experience. And this is a key concept from the sociological lens that you often find in this discipline, which is to say that there is no true objective reality. Therefore, your patient's feelings are all tantamount to objective truth in their own domains. Now, obviously, there's a limit to this. Clinicians are trained to recognize delusional symptoms or manic episodes or psychotic episodes and be able to help filter the negative behaviors that are associated with that so that a lot of damage doesn't get caused as a result. The problem isn't with that. The problem is with these more subtle situations where somebody is experiencing something which is out of bounds with, like, what is objectively happening. And I've seen this happen before, the clinician is unable to distinguish between their internal and external reality. So that therapist that you have has a very difficult time being able to help guide you in an objective way or in a directional way when you otherwise might really need it or are looking for it. Now, this has further implications for political activism that represent other issues, but suffice it to say that this covers the first problem. Now, the second pertains more toward the structural issues with how a lot of clinics work, and the first issue I'll address is vetting. To be a therapist means that you need to have graduated from a undergraduate program and then a graduate program, and then you will have needed to ascend the ladder up into the point where you're capable of getting licensure if you want to work in something like private practice. And within this general education and licensure process, a clinician can gain many skills, but there is actually no preemptive system in place for ensuring clinicians stay within their expertise. In fact, clinicians may often end up seeing clients with problems or symptoms outside of their clinical competency. This informs a bigger problem, however, about the nature of therapy from a structural point of view, because clinics aren't by proxy set up to deal with specific conditions. And a lot of that is tied to a similar dynamic that I just talked about earlier on in the video, about the nature of therapy and private practice and individual counseling being informed from a more sociological lens from the point of view of the clinicians, and less so about other forms of science like behavioral science or cognitive science or even natural science. So you often find that the areas therapists work in, like clinics or hospitals, don't categorize and specialize in different conditions in the same way that doctors specialize in branches of medicine, such as gastroenterology or hematology. In the long run, this is probably one of the more damaging blows to the integrity of therapy, because it's hard to be able to actually meet people where they are and get consistent results if you don't have the mechanisms in place to cater to people's specific needs. Now, other structural problems exist as well, such as the financial incentive for more experienced and skilled therapists to move into other areas of the field, such as private practice or running their own clinics, because this creates difficulties for prospective clients who need this type of care. But again, I could make a whole video on that separately. Instead, let's move on to how to buffer these problems and increase your chances that therapy works for you. From the point of view of the prospective client, what I would say to you is that one of the better ways to prepare for therapy is to understand that it is usually a little bit of a drawn-out process, meaning that the results may not be immediate and you may need to get to know the practitioner and work on treatment goals and do some other things like vetting them before you really start to notice a difference. But what can help expedite this is being able to come up with goals with your therapist. Some important signals that the therapy is going to be conducive to long-term outcomes might include feeling that there's mutual collaboration, adequate support, palatable reframes, and, most importantly, agreement on treatment goals. Now, when you meet a therapist for the first time, it is like an interview process because you're deciding whether or not you want to hire them. So asking the right questions about what kind of practitioner they are, where they come from, what their outlook is on like whatever the relevancy of your problem is. These types of questions are important because they'll help you to frame whether or not this is somebody you want to work with. And if they come off to you as reasonable, competent, intelligent, any of these metrics that are important to you, then the second part of that becomes developing the treatment plan. Talking about goals, talking about if they're pretty good therapists, you can talk about ways to measure those goals, what metrics you use, how you're going to know when you've achieved things, what are you going to do in the short term, the midterm, the long term, all these things. And if you find that everything's copacetic, this leads to the second stage, which is really doing the work. As I alluded to earlier, therapy can be hard because of unforeseen challenges arising from a lack of insight and reflexive defenses to challenges your therapist may make regarding your behaviors or ways of thinking. Making yourself open-minded to new approaches and avenues of thinking is once again a learned skill, and working on this through the course of therapy can really net you life-changing realizations. Now, if we turn our eye to practitioners or as therapy as an institutional model, there's a couple of things that need to happen to ensure success happens as a result of therapy. Number one, a better vetting system for new therapists needs to be established. This is so that competency is ensured and integrity of the practices can thrive. Number two, more effort needs to be made towards integrating specialized care across clinics and hospitals. Number three, therapy needs better marketing. And again, this is one of the more pressing aspects, as currently the space is dominated by infotainers and short-form content that takes away credibility from those ambivalent towards therapy. And finally, number four, a shift in the scientific aspect of psychology needs to be made away from sociological precepts. Now, obviously, this doesn't capture everything wrong with psychology as an institution. There's still problems with payment structures and financial incentives with people who work as clinicians in different clinics or hospitals. But what it does do is capture the zeitgeist of psychology, and it does talk about sort of the intangible problems that exist there that need to change, so that some of these other structures can change or set up new ideas for policies to be created. But as far as individual practice goes, therapists can integrate and execute some of these in their own professions, such as making palatable content or staying current with up to date research on evidence based practice and theory. If a therapist can do that, while staying conscientious of the fact that each person is unique and comes with their own inner world of experiences, then they're bound to thrive in this profession if this creates more hope instead of failure. Creating measurable goals with patients and having the capacity for objectivity and a sense of direction will further bolster your effectiveness to intervene when needed. Therapy really can do a lot for you. It can give you a sense of purpose, it can realign you with old goals, it can help you better understand yourself and navigate your life in a dynamic way. But what happens is that a lot of people really need to find themselves a practitioner who's capable of bringing that out of them. And through some of these things we've been talking about, I hope that I've given you the tools to help find them, and I hope I've given some of these practitioners a way to help integrate things that they may not have considered before into their overall practice. Thank you for watching. If you enjoyed, please feel free to drop a like and hit the subscribe button for more content like this in the future.